Okay.
So I'd like to add one thing. So your knowledge of memory and the impact of various anesthetic drugs on it is, you're one of the world experts on. So you have an understanding, as you just painted, in terms of the different pathways that are intact, even with overwhelming doses of anesthetic, that have influenced you tilting towards safety rather than persistent, to use the term, persistent lack of response or persistent lack of wakefulness or persistent lack of unconsciousness. We use those terms in anesthesia much more loosely than your expert knowledge uses them. So it's important, I think, for the listener to understand that your positions are based on your scientific studies, which are much deeper in your understanding of how anesthesia impacts the brain than the rank and file anesthesiologist in the trenches.
Well, that's true, and my expertise is the explicit memory. The memory we usually think of as memory, anesthetic drug effects on that. The issues about emotional memory, implicit, unconscious, subconscious memory, that's certainly not my area of expertise in terms of my research, but of course I'm familiar with it from the literature regarding memory systems. But I agree in terms of the general practicing anesthesiologist, their depth of understanding of memory systems may not be as deep, but I think that's changing with education. And that's why until we have more data that can support clinical practice, I think we should restrict descriptions of these events into more neutral terms that don't carry additional meaning to people not in the field.
Okay. So one last thing. So I have to offer myself as the example of recovered memory or however. Again, I don't use the terms precisely, but so the way I came to it was I had an anesthetic when I was very young, between 5 and 7 years of age. I had about 5 surgeries when I was young, and on the last one, I was basically what I could figure happened. I was paralyzed and awake on induction and for skin incision, and felt like I was suffocating. And when they did the skin incision, the pain was unbelievable, and then I fell asleep. And I had nightmares of that image for years, but didn't understand it. And then I stopped having the nightmares. And then in my 4th month, it was all over. He wrote what his experience was. I had a panic attack, but didn't remember. I didn't know why. And then when I anesthetized my first child with my attending, pentothal induction, sucks, fasciculations, and the kid went like this when I was about to intubate him. I had a flashback to the nightmare. I said, oh my God, that's exactly what happened to me. And, what I realized, and then I met Bessel van der Kolk when he was coming to some of the meetings in the early to middle phase. And he said, and I entered one of his studies, and he said to me, you really need to leave anesthesia. And I said, why? Because I had filled out all the questions. He said, because your experience in anesthesia has constricted your life experiences because of the trauma you had as a kid. And when he explained it to me, I understood that he was perfectly correct. And the way I reacted to that trauma was I stopped really dialoguing with anesthesiologists, and I went down a pathway. I stumbled into the cardiac anesthesia thing and the transesophageal echo thing, and I said to myself, given the pushback I had from my peers when I told them of my experience, which wasn't positive, it was kind of like what I learned in the trauma literature, that when you have a victim of volcanoes or terrorism or whatever, in a community, the community embraces you and is very protective of you, but after a while they don't like having you around because you're a reminder of something they can't control. And that's basically how I experienced my career in anesthesia. And I learned not to talk about it. And I decided to go down this pathway of doing TE studies so that I could establish my credentials in the field, so that when it came time to talk about it, people just couldn't dismiss it because I couldn't prove that happened to me as a child. I understood what a lot of the skepticism was. And what I found in coming to these meetings and working on the Cochrane Review was, in my attempt to dialogue within the technical language of anesthesia, I came to the conclusion that, for all the reasons you're pointing out, the topic is subtle and difficult to identify the issues and terms for all the reasons your work has suggested. And I viewed your progression on your position on this as very important because you're obviously a very nice person, and I don't agree at all with amnesia as a post-operative target for defining adequate anesthesia, but I totally get why you feel that way. And to me, that's the challenge that we have in anesthesia in dealing with this issue, which is, when you do anesthesia every day, you deal with life and death issues, you deal with complicated surgical issues, political issues in the hospital, and there's a lot of peer pressure in anesthesia to kind of define issues in a way that's acceptable to the community, but I feel like there's almost a community pressure to downplay or minimize or undercharacterize this whole problem of implicit emotional memory, based on my own personal experience.
Well, I think that's a very nice description of events, and certainly helpful to other people in that situation. I would put to you that it's really not implicit memory, that it was a very vivid awake memory at the time that nobody corroborated or
but then I
took
forgot
into
about it.
account.
But how do you explain how I forgot about it?
Well, there's certainly repression is a big factor. And so I think it's a bit different. I don't want to, nitpick, but I think it's a bit different than implicit memory.
No, tell me. Then my response to that is, but that's still clinically important, though.
What I think is important is, and when you're with your childhood experience, to have that recognized immediately and intervene at that point to really help you through that episode. Now, if you so I suspect you really remembered what actually happened during your anesthetic.
But I didn't understand. I didn't understand that. Right. So when what I do remember was, wow, this is a really awful nightmare. I had no connection.
Exactly.
Even though it was literal, but I had no knowledge of what happens in surgery.
Well, I think this kind of relates to what was said yesterday, which is that the vast majority of children who probably have episodes of awareness with full recall don't process that experience in the way that an adult would. And the consequence of that is that they don't present with the typical emotional sequelae of an adult having had accidental awareness. But as we've said, it's not that the memory isn't there or it's somehow ablated or even repressed, but it is still there, and it takes a cue in adulthood that causes it to come out.
Right.
And I'm just very aware that I have a brother who is a pathologist, and he's now in his 50s, and still to this day, about once a month, he has a nightmare which basically replays him having a gas anesthetic in the dentist chair. And basically, I won't bore you with the details of it, but he has a replay of that experience. I think at the time when he was a kid, it probably didn't bother him as much as it bothers him now, which is to do with, I think, the maturation of the CNS and the fact we take on a lot of different forms of knowledge, which then place the experience of childhood in a different context, and you get a different interpretation and different emotional response.
Right. Well, and I would also, you may find some parts of the presentation I'll be doing most interesting, because I think some of the material I present will speak to some of these issues. So I think in terms of the scientific study of all these events, we have to be sort of clear in terminology and try to separate out different pathways and not make presuppositions. And with an event such as that, no one will know for sure whether it's an explicit memory, whether it's an implicit memory that's broken through or whatever. But in a point, that doesn't matter, because what matters is what's going on now and how best to address the issue. And I think the earlier we can intervene in this type of situation, the better off the patient
But don't you
is.
think also that paediatric anaesthetists have a responsibility to make sure that events of the kind that Anthony suffered don't recur?
Well, yes, of course. And I think the drugs we're using now are much better than in those days.
So one thing, so then I get back to the neuromuscular blocker issue. Let's do just issue of spinal cord reflex. It's okay to paralyze because you're not conscious. That whole pathway that our ramp hole kind of made highlighted. But my view is, okay, so let's say it's spinal cord reflex, but if you don't give more anesthesia, analgesia, hypnosis, whatever your choice is, it'll eventually evolve into the patient waking up and trying to jump off the table, no?
Not necessarily. Once again, it's there's no set algorithm, and sometimes the correct thing may be to use muscle relaxant, but I think you have to go down the list of other things you might want to do and eliminate those before giving more muscle relaxant.
So, but what about the analysis system of, I know we'll go, I'll wrap it up with this one point.
Yes,
So, but you don't know what that outcome is from the spinal cord reflex. You don't know which pathway they're going to go, whether they'll eventually wake up if you don't give anything to jumping up. Don't you have to assume that that's what you want to treat rather than the neuromuscular blocker because you don't know what the end result if you go unintervened?
Well, I think Michael Avedon made the nice point that we probably people use muscle relaxants more than they need to be used. Anesthesia can be done satisfactorily with fewer muscle relaxants. Once again, I think there are no good data to show what should be done in the case of movement. If somebody just moves their arm a little bit, are you going to deepen the anesthesia? Versus, obviously, if somebody sits up on the table, that's an entirely different situation. So I think it's a complicated answer, and I think, once again, we have no objective monitors of what the movement represents. We just have to use our clinical judgment.
So would you say, so with remifentanil and propofol, the first combination of intravenous anesthesia using it in a generic sense, first TIVA, where you don't need muscle relaxants, where you can titrate to lack of movement and still extubate them, shouldn't that free the anesthesiologist into, even though we don't know what pathway that initial hand movement's going to be, shouldn't that lead us to wanting to titrate short-acting anesthetics to lack of movement, since we can't figure out until it happens whether it's an unimportant reflex or a more important regaining, being awake or conscious, whatever you want to say?
Well, I think you point out we need to understand what's going on better than we do now. I think we have a looming problem with muscle relaxants, and we need to somehow address how we're going to handle that. For instance, now most of the surgeries, a lot of the surgeries are robotic surgeries. Surgeons are more and more mummifying the patients for their surgical procedures, having both arms tucked. The anesthetist is off in the corner of the room, surgeons doing robotic surgery are now requesting deeper and deeper paralysis for their robotic procedure.
But shouldn't we subject them to the same outcome measures of the superiority of robotic procedures to standard procedures because of the implication it has for the anesthetic protocols?
Well, yes, and I think there's actually pretty good data to show that there's a significant reduction in postoperative infections. So that's going to be a major outcome that's going to be of great interest to most people. So I think, in a sense, the train has left the station. So we need to figure out how we're going to deal with our anesthetic management with muscle relaxants. I agree, you don't use muscle relaxants unless you need to, but we're going to end up in that situation, and we need to figure out an algorithm to give the best patient care in that situation. And I don't know what that is, but I think it's an issue that's coming to the forefront.
Yeah, we better stop.